Thank you. So as you already heard, one of my first messages is that this meeting will be recorded. So welcome everybody to the Greater Manchester Connected Health Ecosystem event. So hopefully all joined on the right event. This one is going to be focusing on the secure data environment. I am Kiran Patel. I'm a GP in Bury and medical director of the GP Federation there. But I'm here today probably in my capacity as chair of the secondary users and research group that is across GM that works with the secure data environment. So today we've got a series of speakers which I'll go through in a minute. Just some house rules to start the event is that, as you've already heard, the event will be recorded for promotional purposes. So please, if anybody has any objections to that, please raise them now, but obviously that is important for us to record this event. This is a Zoom meeting, so those of you familiar with Zoom, there are several ways you can communicate with the team, and primarily the chat function. So please feel free to post any questions that you have to any of the speakers, or general questions about the secure environment into the chat box, and we'll try and collate those questions and answer those as we go along. After each speaker, we will have an opportunity to ask a question or two, but there is a significant chunk of time at the end of the event for people to ask questions. So please feel free to ask, raise any issues that you might have in the chat box. You're all probably familiar with the raise your hand function as well. Obviously, with a number of participants we have, I may not be able to get around to every single hand, but those who want to ask a specific question and want to clarify a question, then please raise your hand as well. We will collate all the questions in the event that we don't get around to answering everything, and we'll feedback any things that we were not able to clarify in the meeting in a document afterwards. And obviously, for those of you who want to tweet and use the tweet function, then there's the hashtag there for you to do that as well. Well, can you move on to the next slide? Okay, and just for the speakers as well, I should have said, could people try and keep their mics on mute as well? And videos sometimes are better switched off as well in terms of helping with people's bandwidth as well. Okay, so basically today the conversation is about the secure data environment that's been developed through Greater Manchester. What we would like to get hopefully provide a better understanding of how that has developed over the last couple of years. There's a lot of effort being put into developing it, and hopefully we can kind of show you some ways that it has already been used, reassure you on all the governance processes that are in place, and the safeguards that have been put in place so that you can protect the integrity of the data and to give you the confidence that you're working with data that is well harvested. We've also got speakers from the patient and public participation group as well, because we've been very, very active in making sure patients and public understand what's been happening with their data and are involved in the architecture of this process. It's really important that people who are involved in research understand that the environment that's been created, and those of you who are in the process of putting bids together for research, this would be really useful for you to understand the environment that's been created so that you can start thinking about whether this will help in your grant application forms. And there's also going to be an opportunity as you go through the event today to understand the ability for you to feed in to help us develop the architecture forward. So there will be opportunities for you to define the kind of characteristics that you need of that environment. So we'll share a link later on to allow you to kind of do that as well. So you've got the agenda there in front of you. So if we start with the first speaker, which is Bradley, who's the Associate Director of Insight at Health Innovation Manchester. Bradley, do you understand?
Thank you very much, Kiran. I'm just going to share my screen. So could you just let me know when you can see this okay, please, Kiran? It should come up any minute now.
Yep, we've got it up now, Bradley.
You can see that? Fantastic. So yeah, hi everybody, and a big thank you again for joining today's session on the Greater Manchester Secure Data Environment for Research and Development, formerly a trusted research environment. As Kiran said, my name is Bradley Quinn. I'm the Associate Director for Insight at Health Innovation Manchester and the Greater Manchester lead for our TRE programme. Our aim as Health Innovation Manchester, as I'm sure many of you know already, is to support how we discover, develop and deploy new innovation. And a big part of that is how we use data to develop new solutions that can really transform care for patients. So briefly, just to talk about the objective of today's session, my first slot for the next 15 minutes or so. Many of you have heard already about some of the recent developments around investment in secure data environment. And in today's talk, I want to try and give you an idea of why research and innovation is so important to the NHS in Greater Manchester, the role of secure data environments within that, and how this quite transformational shift in how we use data is already making a significant impact here in GM in Greater Manchester. So first off, just to give you an idea of GM for anybody who isn't familiar to begin with, and a bit of an overview of our city region. So we're an area of about 3 million residents in total across 10 individual localities. Within that, in GM, we have a very diverse population, bringing together communities of all different backgrounds, as well as areas of affluence combined with areas of quite high deprivation, so the most deprived areas in the country. We're covered in GM by a single integrated care system, the second largest ICS in the country, and that reflects a partnership between all of our health and care organisations and the broader public sector, including over 450 GP practices, 10 local authorities, 9 trusts, including 1 specialist trust, 2 mental health providers, almost 700 community pharmacists in total, and 4 universities as part of that system. We've got significant health inequalities in GM, and many of our citizens live with poor health outcomes, a lot of which are considerably worse than the national average. Against many of the big health challenges, we have really entrenched problems with higher rates of mortality, morbidity for things like cardiovascular and respiratory disease, diabetes, obesity and smoking and the like. Alongside that, though, as many of you know, we in GM are renowned for being a highly collaborative, highly civically engaged city region. We were the first area anywhere in the country to secure devolution, and that included full devolution in 2016 of the health and care budget, £6 billion. And that's very much set the blueprint for the integrated care system approach elsewhere in the country. Crucially, and I think particularly for today's conversation, we also have a thriving and energetic life sciences, digital and innovation sector. GM has the largest life sciences cluster anywhere in the UK outside of the southeast of England, and the largest digital hub anywhere outside of London. So that hopefully paints the picture in terms of who we are as a Greater Manchester City region. And supporting that across GM, we have a really rich and internationally recognised health science and innovation ecosystem. So on the left of this diagram, you can see our 4 higher education institutes, the universities that I mentioned earlier, each with their own expertise and international recognition. On the right, you can see the variety of organisations that make up the NHS across GM and the various organisations involved. And that includes some very research active foundation trusts like the Christie, who are obviously a world leader in cancer treatment and research and the host of the Manchester Cancer Research Centre, people like the Northern Care Alliance and Manchester Foundation Trust, which is the largest acute trust group anywhere in the country. Then in the middle, you can see the myriad of organisations that help to bridge the gap between the two, with a focus on how we build research and innovation capacity and capability and start to put some of those things into practice. So that includes all of our NIHR infrastructure and organisations like our Biomedical Research Centre, the Patient Safety Translational Research Centre, our CR and our CRF, and Health Innovation Manchester, you can see there in the middle, which is the organisation where I work. So I've included on this slide a very clear and very strong ambition from NHS England nationally, which recognises the absolute importance of research and development in the healthcare system. And this quote is taken from the National Data for R&D programme. And you'll see it's all about how, as a country, it's our aim to have world-leading research infrastructure that supports primarily 3 things. It should enhance patient care, it should sustain the NHS, and it should support innovation. And that's all really about how we realise the potential of the UK's quite unique health data offer. And it's within that national context that we as Greater Manchester are operating in. So just to give you an idea from a policy and strategy perspective, the national mandate for supporting R&D at this point in time couldn't be any greater than it is now. And I've summarised on this slide a few of the important strategic drivers. Many of you will be familiar with lots of these recent landmark publications already, but just to give a brief summary. So first, on the left-hand side, the UK industrial strategy and the life sciences deal, with an ambition for R&D spending to reach about 2.5% of GDP by 2028, and that equates to about £14 billion in total. A big element of that for Greater Manchester specifically is the focus on levelling up and how we address regional disparities. That includes significant investment in 3 innovation trailblazers, GM being one with our real focus on health innovation. Many of you will have seen on that second column the recent review Better, Broader, Safer, otherwise known as the Goldacre Review, conducted by Ben Goldacre and the team, who were commissioned by government to try and improve the safety and security of how we use health data. They made 185 recommendations in total. They engaged with over 100 stakeholders with a real heavy focus on the importance of trusted research environments, as it was called at the time. There's also the Department for Health and Care's vision for the future of UK clinical research delivery, and that builds on the lessons from the pandemic and our ambition for world-leading UK clinical research environments. And then finally, on the right-hand side, you can see there the life sciences vision, and that's obviously government's 10-year strategy to accelerate delivery of new treatments. But there are many more. I could have easily talked about the long-term plan, Genome UK, the Data Saves Lives strategy. But ultimately, the message there is that there is a significant drive to do things differently in this space and to make the UK a real recognised international leader. So turning then to secure data environments, SDEs, as a critical enabler for everything that I've just mentioned. And first off, I suppose, what exactly is an SDE? Well, previously these environments, as I say, were known as TREs, Trusted Research Environments. And nationally, the terminology has changed recently to recognise that the term SDE is more accessible based on patient feedback. And recognises that oftentimes their usage extends beyond just research. The concept of SDEs has been around for a while. People have talked about data safe havens, for instance, but there's been a big push following some of the recent coverage around national data collections for GP data in particular. You might remember the Health Secretary at the time standing up in Parliament to say that the national collection would be paused until 3 specific conditions could be met. The first, that patients had to have a very clear process for opting out of any data collection. Second, that there needed to be further communication and dialogue around sharing of health data for research. But third, and importantly, that any data would only ever be accessed via a secure data environment. And there are 2 really useful definitions which I've included here on the slide from both HDR UK and from HS Digital. But fundamentally, SDEs shift the way that we use data. Rather than taking the traditional approach of sending out data, researchers come to the environment and access it once they've been approved and they've been audited. And any of the stuff that they decide to take away from that environment has to be checked before it's released. So to use a bit of a metaphor, you're probably wondering why I've got this picture on the screen. I like to think of SDEs as a bit of a virtual version of those glove boxes that you get in a physical lab that contain some sensitive material that needs to be handled really carefully. If you think in that metaphor, the sensitive material in the glove box is patient data, and the glove box itself is a secure data environment. You can still interact with the data and do really important, crucial things with it, but it's in a safe and managed and controlled way. And that gives you an idea about what an SDE is. So if working in this way, if using SDEs is such a fundamental shift, it's important that we're able to really clearly articulate what the benefits of that transformation are. And I think it's fair to say there are very clear benefits for all stakeholders involved. So most importantly for citizens, this model of secure data environment demonstrates trustworthy and transparent data access, and it helps to build that public confidence, as you'll hear a bit more about later on. It means more people are able to participate in research, and they're willing to participate in research because of that trust, and that ultimately helps to tackle inequalities. For the workforce, it means that we remove some duplication of data collection because we're reducing extracts and copies of the data. We've got a single version of the truth. It helps to create jobs for inward investment, and it means that we can generate some really useful tools, things like decision support tools, early diagnosis, risk stratification models, and AI, for example. For researchers, by keeping them absolutely at the forefront of our mind through user-led design, they have a positive experience, hopefully, of accessing the data. But because they're coming into the secure data environment, it means that they can get access to a richer, wider set of data than may have been historically possible when we were sending out and sharing data assets. And they have the ability to link to that data securely if it's appropriate to do so. And then finally, on the right-hand side for industry, by delivering this, UK attracts more inward investment. We're on a much stronger footing to conduct advanced trials faster. And on the ground, we can hopefully help support that translational gap of putting innovation and translating it into care more quickly. I've got 2 more slides I just wanted to touch on briefly, just to give you an idea of our journey so far in Greater Manchester and where our priorities are for the SDE programme moving forward. And as I mentioned previously, getting to this point has very much been a journey for Greater Manchester that started, if you can think back on the back of devolution, way back in 2017. It seems like a long time ago now. And since then, we've been invested in this work. It's been a continuous priority for us. And we've always intended to share that learning to inform national developments and policy in other ICSs. So to take you through a couple of key milestones through that process. So starting back in 2018, GM deployed an ICS-wide, or rather an SDP-wide as it was at the time, data warehouse that was accessible to all partners, which really was the beginning of lots of the infrastructure which underpins our secure data environment. Then in March 2020, the entire world changed with the COVID pandemic, and because of the way that we needed to respond and how patients were being managed across areas in a way they never had been before, with hot sites and cold sites from a COVID perspective. Previously, there'd been lots of locality-led record sharing, but COVID meant we significantly accelerated city-wide data sharing across the entirety of Greater Manchester. But alongside that, we also sought to use that data and leverage that data for research and analysis purposes. The care record that we use in Greater Manchester is supplied by GraphNet. They cover about 1/3 of the English population with shared care records. We were the first GraphNet customer anywhere in the country to deploy a tactical trusted research environment in that shared care record. And we use that to conduct almost 20 research studies using real world data to understand the impact of the pandemic here in GM, as Niels will touch on a bit later on. In November that year, so in just 6 months' time from initial deployment, we had our first publication using care record data, so a really rapid turnaround. And since then, we've been doing a lot of work to migrate our SDE capability from that tactical environment in the care record to the wider GM Analytics platform, which Matt will tell you about in the next session. We received some funding from HS England last year to support that, and we used that cash to successfully deploy our secure data environment in a box within that analytics platform. So as of the summer, that secure data environment is now up and running and operational, and we have that secure data environment deployed. And we'll soon be looking to conduct a number of initial lighthouse studies to test and enhance that environment as we move into the spring next year. Alongside all the technical stuff, there's been a massive amount of work to build the wider service wraparound, to establish our sustainable information governance, as Jenny will touch on, to build trust and engage with the public, as Nikki and Pat will talk about, all while successfully delivering some really high quality research studies, as Niels will outline. So the final slide from me, and I guess where next for the GM SDE? Well, our first and primary focus has to remain local in terms of how we continue to develop this environment, always thinking about how we continue to build on what we have to keep Greater Manchester absolutely at the forefront of research and innovation. And on that point, I think there are 2 areas I really wanted to emphasise. First, as I mentioned on the last slide, the SDE in GM exists today. We're doing lots of work to continue to link data sets and bolster our governance, but we want people to be aware, as Kiran mentioned at the beginning, when you're writing grants, when you're considering research in GM, that this is an asset that's already in place and that you'll be able to use and access in the not too distant future. We're hoping to conduct some lighthouse studies and then be in a position to consider additional projects in spring next year. So do bear that in mind when you're writing those proposals. Second, this is a constant process of reiteration, development and feedback. And we're about to undergo a big process of requirements gathering for the SDE, and we want to hear from people. People like all of you who are end users of the SDE, as to what you need from that environment and the kind of features that it needs to have. Ruth and the team are very kindly going to post a quick link in the chat for anybody who's interested in being involved in this SDE requirements gathering piece in the process, so you can share your contact details, and then a member of the team will get in touch. We want the SDE to be fundamentally driven by user needs, so any of your input through that process is absolutely crucial. So there are big 2 priorities in the near term in terms of our local focus. deliver research to demonstrate benefit and build that capability. But in parallel to that, we've recently submitted an expression of interest for national funding from NHSE as part of a wider Northwest collaboration. If that expression of interest is successful, we'd be the largest subnational secure data environment population anywhere in the country, covering a total of about 7.7 million patients. We're optimistic in terms of that outcome, but we're hoping to be notified soon. We want to carry on influencing and shaping national policy. So take the learning that we've got in GM and use that for the benefit of others. And we want to work together to look at how we can share and solve problems together. And most importantly, all through that, we want to carry on delivering for the people of GM. We want to do even more exciting research, even more interesting innovation, and collaborating with our partners. So hopefully that provides a decent overview of the SDE program, what our priorities are, and that's everything from me. I'm going to hand over to Matt in a second to take you through the next session. But do remember, if you're interested in being contacted around that requirements piece, please do share your details using the link that Ruth and the team will post in the chat. Thank you, everybody.
Thank you very much, Bradley, for giving us that overview. Bradley, there are a few questions in the chat box which are specifically to you. So if you can have a look at those and reply, and then we can maybe pick some of them up at the end, if that's okay.
Yeah, that's
okay,
great.
so as highlighted by Bradley there, we'll move on to the next speaker. So that's Matt Hennessey. Welcome, Matt. So he's the Chief Intelligence Analytics Officer. So he's going to talk you through some of that analytics work that Bradley mentioned. So over to you, Matt.
Thank you, Kiran, and hello, everyone. So as Kiran said, I'm the Chief Intelligence and Analytics Officer working for NHS Greater Manchester, which is the new organisation that has been formed at Greater Manchester level, which was the sort of merger of 12 legacy organisations, CCGs. I'm also the system sponsor for this piece of work. So on behalf of the whole system, the Integrated Care Partnership, and the bit that I'm going to talk about, Bradley's teed up nicely, because you're probably starting to think about the SDE and wondering what's in it. So I'm going to talk you through the sort of data that's in it and how it will be used, not just for research, but also for operational purposes. In theory, an SDE could be, you could have an SDE that's just built exclusively to serve research and development purposes, and have a completely separate SDE to manage your operations, the flows in hospitals, the flows in primary care, things like that. What we were keen to do from the start is have the same SDE serving both research and operational activity. And the reason for that is we wanted to remove any sort of barriers to operationalizing some of the great research and actionable insight that research partners could generate. So if you manage to build an amazing model that predicts exactly how long somebody's going to wait when they go to A&E, we'd love to be able to surface that very quickly into the operational workflows of A&E. So if you have two different secure data environments, one that works with the research and one that works with operations, you've got a barrier to migrating that model across. The idea in the GM system in Greater Manchester is that actually both applications sit on top or within the same secure data environment. So I'm going to walk and talk through this picture because hopefully it'll make sense that way.
Are you able to share it in a slide view? It might make it a bit bigger.
So Ola, I think, is driving the.
Okay, sorry, Ola. Sorry.
Yeah, sorry, apologies. It's coming.
So I should start by saying that Greater Manchester, the NHS in Greater Manchester, is slightly unique relative to other integrated care systems in that we've been on a devolution journey, and as part of that devolution journey, we have been we retained an NHS England identity, which meant that we could access data that NHS England have, and I will talk you through. I'm going to start at the left here, under where it says source data, just to talk about some of the source data that we have. We have each Integrated Care Board and Integrated Care System has been asked by NHS England to establish a record level, so a pseudonymised record level longitudinal linked data set. So linking primary care, secondary care, to some extent tertiary care, and in due course making sure that adult social care is linked, so that for every patient you wouldn't necessarily know who they were, but you would know that such and such a person was this age, they lived roughly in this area, they had these protected characteristics, and we can see that they went to a GP on this date, they were seen by a health visitor on that date, they turned up in A&E here, they were an inpatient there. And so you could see the longitudinal record of an individual. Now, to create that longitudinal record, what we need to do is we need to take the source data on the left there, which we get through various routes. So the NHS trusts and providers submit data to NHS Digital and NHS England nationally. There's a whole bunch of abbreviations. Some of you may be familiar with them, things like SUS and HES, and basically that's hospital statistics or mental health minimum data set. There's data around vaccinations following COVID and testing, things like that. That all goes up, sent up nationally to help performance manage and commission. And because we had an NHS England identity in Greater Manchester, we were able to access that. And that data currently gets linked for us by what they call the DESCRO, which is a data services for commissioners in the regional office. So anything that gets sent by trusts nationally, effectively we get some access to. We also get local flows from NHS trusts, which aren't yet national collections, or they're specific to Greater Manchester. So some of the local flows we get, for example, we have a local flow which is a live A&E flow. So at any given time, we can tell how many people are awaiting in emergency departments around the region. We also get discharge data set. So this is understanding when people have no reason to reside, they're medically fit for discharge but haven't been discharged yet. So we need to know why that is. Is it because there was no care home capacity to discharge to, or did they need prescribing before they were discharged? So we're collecting lots of local information too. There's then the community side, so the primary care, adult social care. Now, most of the primary care data now flows into what Bradley referred to as the Greater Manchester Shared Care Record, the GraphNet is a supplier for that. And that allows clinicians around, whether they're in secondary care or primary care, to view somebody's record in order to provide the best care for them. But it's also a valuable source of data for commissioning or secondary uses. So the plan we have is we have these already established, and a lot of places around the country don't have a single shared care record for the entire system. We do, and we do have access to both local flows and national flows. And the intention within our secure data environment is to link all of these things up. So we're going through information governance processes that I know Jenny's going to touch on later, that will describe how we link the data and how we ensure that it's robustly and securely stored. The secure data environment has a load of tools in it. And once we've linked the data, we will have in the center there a shared patient level longitudinal record. Our priority at the moment is to ensure that it has that it's event driven, so that we can see the events. But over time, there'll be more clinical notes or appropriate qualitative information in there. And we have a load of tools that allow NHS commissioners and analysts to access it. Where we get to the right-hand side is the distinction we're making between operational activity So we have a sort of single analytical front door for people who are interested in operations and viewing dashboards and monitoring performance and commissioning. But we've also had what we described as which our sort of trusted research element of this. We, as Bradley said, we're now in a position where we have the facility within that sort of central secure data environment to stand up almost like he was saying with his gloved lab box. You've got a secure environment where with the right permissions, researchers can go in and access the data they've been given permission to access, and the secure data environment will serve into that or expose into that kind of that gloved lab box the data that people need to work with. And the lab box should have within it all the tools that researchers need. So it will have content management software, research management software, referencing, analytical tools, Python, R, those sorts of tools, metadata catalogs, things like that. And I know that Niels will probably pick up in some respects on that. So that's the infrastructure. You can see that hopefully when this is it's in operation now, but when all of these data linkages have come together, you will have a shared patient level longitudinal record that will allow you not only to track the sort of evaluation outcomes for individuals within the system, but to cohort. So you might be able to say, okay, I want to see all the data on all the over 50s who have had a stent intervention, and I want to see what happened to them as a cohort before they got the stent, and what were their outcomes afterwards. So I'm going to stop there because I'll be handing over to Niels, I think, next to talk about some of the use cases.
Thank you very much, Matt. And there are again some technical questions in the chat box that you might want to pick up as the next speakers are speaking. So thank you very much, Matt. Okay, so we're now, as Matt said, moving on to Niels Peake, so Professor of Health Information at the University of Manchester, who's going to take you through some examples of how we've already utilized this environment in the last couple of years. Over to you, Niels.
Thanks, Kiran, and thanks, Bradley and Matt, for the introduction to the secure data environment. I'm going to talk about research use cases that we hope to support via the secure data environment. So indeed, I'm Professor of Health Informatics at the University of Manchester. I'm also Director of the Christopher Pankhurst Institute for Health Technology Research and Innovation. And our role is really to help define and drive those research use cases for which the environment is going to be used. And already throughout the pandemic, we've been working very closely with Health Innovation Manchester and the combined authority, and to drive analysis of the Greater Manchester Care Records. So just before I start, I'd just like to reiterate something that was already touched upon by Bradley. The unique opportunity that we have with electronic health records in the UK, and coming from abroad myself, I'm very much aware of how unique those opportunities are. So obviously in the UK, we've got a universal healthcare system which is free at the point of service, which means that nearly everyone uses it. So there are very few gaps, if you will. Each individual has a unique NHS number that enables us to identify them in different data sets and link those records together so we can follow them in their journey through different NHS organizations. And more than 90% of citizens are registered with a GP. So GPs have used electronic health records for more than 20 years now, again, which is, I think, really, really unique. So they've been paperless throughout that period. Some GPs have actually used electronic health records for even a longer period of time. Those records are highly granular and complete, for instance, with respect to long-term conditions, but also many other things. And they use coding standards like the read codes and SNOMED codes to record things like diagnosis and symptoms, etc. Electronic health records are also increasingly used in hospitals, but it's important to note that there are no standards for granular patient data in hospitals. So it's really the more high-level data that we typically have from hospitals. And it's the same here as well in the ADSB. So what we're aiming to do is support a number of study types that NHS England have mandated that secure data environments for R&D should provide, which are the following 6. So the first is AI algorithm development, so testing, training, and validation of new predictive algorithms. Second one is clinical trial activities, so feasibility of clinical trials, so assessing feasibility of clinical trials, assisting in the recruitment of clinical trials, and also improving the efficacy of clinical trials through gathering short and long-term trial follow-up data via electronic health records. So on this front, we're having conversations with Northwest eHealth to see how we can join forces with them. Then C, real-world studies, so assessing the safety, effectiveness, and cost-effectiveness of interventions. D, translational research, academic discovery and implementation of discovery into practice. E, epidemiological studies, so using large cohorts for population health research. And finally, F, health system research, evaluation of systems or processes, including operational and applied research. As I've mentioned, we've already built up experience with using the Greater Manchester Care Record for a number of these different types of use cases. So, for instance, our first study using the Greater Manchester Care Record was conducted by Sarah Steeg. It was published in 2021, and it looked at temporal trends in primary care recorded self-harm during the first year of the COVID-19 pandemic. We've also done a number of health systems research studies. Here's one, which I think is a really nice example, conducted by Ruth Watkinson. And this one looked at ethnic inequalities in COVID-19 vaccine uptake in Greater Manchester and compared that with the seasonal influenza vaccine uptake. And interestingly, that's actually very, very different. So there's different groups who do or do not take up vaccines for COVID-19 and influenza. So we have that experience, but now going to expand it across those 6 different study types. We're aware that studies may come with a number of additional requirements that we will need to be able to address via the secure data environment. So the first is that some studies may require that we link the data that are available in the ADSB to some external cohort data set. So that is certainly one thing that we're going to facilitate, and we've again already built up some experience with doing that, for instance, linking Greater Manchester Care Record to data from the Christie. Then a second requirement might be that we might link electronic health records to other data modalities. So that's a special case of the first one, if you will. So for instance, where we would link electronic health records to images, signals, text, or omics data. And again, that we're very keen to facilitate all of that. Then we may have studies with increased sensitivity due to the organizations that are involved in the study. And there we will use privacy enhancing techniques to ensure that there's no risk of any form of de-identification of the patients involved. And finally, some studies will require a federated data analysis where we analyze data not just from Greater Manchester, but across the Northwest footprint. So we're working together with the Cheshire and Merseyside and Lancashire and South Cumbria ICSs to enable federated data analysis across the entire Northwest footprint, so covering more than 7 million patients. Then in addition to the 6 study types that I've mentioned, we also want to demonstrate capability of the GM secure data environment for data science training. So specifically exposing data science students to the complexity of longitudinal electronic health records for development of their data engineering and analytical skills, and making them familiar with technical infrastructure and data governance processes of secure data environments. I think this is really important because what we see time and again, both within the university but also in industry, is that once data scientists have completed their training, they've never been exposed to electronic health records, so they basically have no experience on that front at all. And it will then take, well, at least a couple of months usually to make them familiar with the complexity of electronic health records. So I think it's important that we try to train the next generation of data scientists and expose them to the complexity of these real-world data. So Bradley already mentioned that we're going to drive things forward using a number of lighthouse studies. So these are high priority system-led studies to drive the development of the GM secure data environment and to demonstrate its capabilities and benefits. So these lighthouse studies will be linked to the study types that I've mentioned, and then prioritized based on a number of additional selection criteria. So the capacity of the team that will be running the study to deliver that study actually, and also within the relevant timelines. Whether there exists a legal basis to conduct the study, that's especially important for data linkage studies. So there we will have to look carefully about what is that legal basis, and again, given the time frames when we want to do things, is it feasible to conduct this lighthouse study? What are system priorities in terms of health needs of the Greater Manchester population, as well as national and regional policies? And then to what extent would studies have additional requirements like the ones I've mentioned on the previous slide, so for instance, data linkage or multimodal data? We'd like to have studies that with those additional requirements so we can build up experience with it, but obviously it has to be things that we can do in the relatively short term. And finally, we will prioritize studies that minimize risks that they would not deliver. So in terms of next steps, we're going to organize a stakeholder workshop to get a good understanding of what it is that people need and require from the environment. We're going to analyze the business processes for the 6 different types of studies. They will each have slightly different processes. Certainly the trials one is, I think, different than the other 5, but so that there's going to be some overlap, but also a difference between these 6 types of studies. And we need to understand very carefully, what those processes look like, so we can make sure that we support all of them through the secure data environment. Then we're going to select the lighthouse studies and implement them. And that was my last slide. Thanks very much. I'm going to hand over to Jenny.
Thank you. Yes. So we're going to move on. There's been a number of questions on governance already, Jenny. I'm sure you've been following in the chat box, so I'm sure you'll be able to answer a lot of those through your presentation. So Jenny Spears, thank you very much. She's Head of Information Governance at Greater Manchester. So over to you, Jenny.
Thanks, Kiran, and thanks, Niels. I'll just take you through, hopefully you can see the slide deck. I'll just put it into slideshow mode.
I can see it, thank you. Yeah. Okay,
so as Kiran said, I'm Head of Information Governance at Health Innovation Manchester. I've chosen this slide deck because it demonstrates the partnership on the integrated care system that we're working to, and I'm responsible for making sure that for some of our digital projects, such as the Greater Manchester Care Record and the Secure Data Environment, the ADSP, that we've got the appropriate information governance in place across the whole of the ICS. So that's predominantly my responsibility. I also chair the Greater Manchester Information Governance Group that's attended by health and care, data protection officers and IG leads across the region, and I'm deputy chair of the National Strategic IG Network as well. So in terms of the SDE, what do we need to put in place from an information governance perspective? And the key elements of that is making sure that we comply with the legislation. And we'll look to the data protection legislation, and that is actually an enabler for sharing information. And we can easily identify the specific articles that we need to comply with to make sure that we've got that legislative way forward for us. In regards to the human rights legislation as well, if we are complying with data protection legislation, typically we will be complying with human rights legislation as well, but that is something that we consider and look at in isolation. And what's key for us within the NHS is the common law duty of confidentiality. And that is in relation to patient data that is shared, and making sure that we comply with that, which isn't a piece of legislation. It is cases that go through courts, and we build up then our knowledge on what we need to do to apply that common law duty of confidentiality and set it aside when we need to. So what we know is that the processing of data within the secure data environment and for research, it's classed as a secondary purpose. And as such, that lawful purpose needs to cover the disclosure and transfer of that data to a third party in order to anonymise or pseudonymise that data set. And then it also needs to cover the linkage of data sets from multiple organisations. And from a secondary use perspective, we will also be doing some auditing, monitoring and analysis of patient care, which is undertaken by those outside of that direct care team. And in order to do that, we've got to comply with that common law duty of confidentiality. And there's a number of ways that can be done. One is patients giving their explicit consent for that to happen. And for some small cohorts, you might look at gaining explicit consent. But predominantly in looking to transfer that data to a third party, one of the routes is for us to gain approval under Section 251 of the NHS Act 2006. And I'll come on to that in a bit more detail. The other element is a statutory or other legal requirement to disclose. An example of that was the COVID-19 Control of Patient Information Notice. That is now expired, apart from GP data still needing to be shared nationally under a revised COPE notice, but only to access data using the Open Safely platform, which is an NHS England initiative. So looking at that Section 251, that is going to be our route for seeking compliance with that common law duty of confidentiality and setting aside that consent element. And what that Section 251 does in its current regulations, which is also the Control of Patient Information regulations, it allows the Secretary of State for Health to make regulations to set aside that common law duty of confidentiality for defined purposes. And it means that those data controllers that are responsible for that information can disclose that confidential patient information without consent, without it being a breach of the common law duty of confidence, if those requirements are met within the regulations. And the person responsible must still comply with all the other relevant legal obligations, as I've touched on, such as the Data Protection Act, UK GDPR and the Human Rights Act as well. Recently, on the 1st of November, the National Data Guardian is responsible for challenging and advising the health and care system on the use of confidential patient information. And she wrote to all the senior information risk officers of the integrated care boards. And the first two activities that were mentioned in the letter related to risk stratification. But activities 3 and 4 are applicable to the secure data environment that we're talking about today. And what she was saying was that if you are transferring confidential patient information from local record sharing programs, so the GM Care record, into secure data environments, for purposes other than individual care, we have to consider how we're going to satisfy or set aside that common law duty of confidentiality. And the recommendation that she put forward was that organisations that wish to do that within an SDE approach the confidentiality advisory group to discuss whether an application for support under section 251 is required. And we've already had that discussion. We've been having that discussion with the confidentiality advisory group and the confidentiality advisory team that supports the CAG over the last few months now. And we are in a position that our understanding is we will be applying to CAG for that section 251 support. Activity 4 as well covers the disclosure of confidential patient information outside of the shared care record team to render it anonymous for secondary purposes. Again, that is a piece of work that we will be undertaking as part of the SDE work as well. So again, we will be putting forward a CAG application to enable us to do that. So what's currently in development is we are working through a data protection impact assessment specifically for the analytics and data science platform. And that will include how we're setting aside that legal basis or complying with that legal basis as well. The CAG application will be submitted to enable the data to be processed by a third-party supplier to enable that to be anonymised or pseudonymised. There will be data processing agreements in place, which we are working through now with the suppliers that Matt mentioned in his slide. And we will be consulting on that documentation and seeking approval by data controllers, specifically GP practices and their data protection officers that, you know, we keep up to date and in terms of what's happening in regards to the data that they are processing within the GM care record. And the other data that we are expecting to receive, as Matt alluded to, via SUS and the mental health minimum data set, etc. With regards to adult social care data, we will be working through a separate data protection impact assessment specifically with local authorities. At the moment, we've got 8 out of the 10 local authorities feeding adult social care data into the GM care record. There will be a 9th next week, and then we are working with the 10th local authority as we speak as well to make sure that we've got that GM coverage. But when we have use cases for utilising adult social care data, we need to get that approval from the local authorities and in specifically liaising with their information governance leads, chief legal officers, to make sure that we've got that legal basis to utilise that adult social care data as well. And that is something that we will be working alongside local authorities to make sure that we've got that in place. In terms of the governance, we have the secondary users and research group, and to that group we take applications for data where those applications would either be approved or rejected via that group. And what's really key is ensuring that we've got the relevant stakeholder review as part of that group, and that it does include public members as well. So this is the terms of reference for that secondary users and research group. Kiran, who's chairing this event, also chairs this group. And you can see that the purpose of that group is to provide expert advice and guidance on the appropriate use of GM care record data for research and secondary users. And we will be looking to expand this group to cover the analytics and data science platform more generally, and the secure data environment for research and development as well. I won't go through the membership, you'll have that as part of the slide deck, but it's something that when we've got specific applications, if we haven't got the membership there that covers it, we will be bringing in those stakeholders so that they are represented at that meeting to consider any applications for that data. So final slide, just a bit of a time frame as to how this is happening. So in terms of the data protection impact assessment, the CAG application, we're working on that as we speak between now and March next year. The secondary users governance, making sure that we've got those relevant stakeholders when needed as part of that application review. We'll be doing that between December and March. We will then be open to those applications and being able to review and look at those applications once we've got that in place. And then we will be ongoing reviewing and making sure that the IG arrangements are reviewed regularly via that secondary users and research group and via the Greater Manchester Information Governance Group as well. There's two key elements to this. One is that governance, but the other one is the public communications and the stakeholder engagement around all of this as well. And I think that probably feeds nicely into the next presentation. So I'll hand back to Kiran.
Thank you very much, Jenny. Again, there are quite a few questions on governance, which we might want to pick up in the Q&A section in a bit. So yeah, as Jenny said, thank you very much, Jenny. We'll move on to the next speakers. So really pleased to welcome Nikki Timmins and Pat Walkington. It's been really important that we engage the stakeholders and the public in this project, and I'm hoping that Nikki and Pat will be able to take us through some of the work that they have done in ensuring that the patient and public of Greater Manchester are aware of what's being done to create this secure data environment and the safeguards that have been put in place. So over to you, Nikki and Pat. I don't know who's going first.
Thank you, Kiran. Yeah, so my name's Nikki Timmins, and I'm the Public and Patient Involvement Engagement Manager at Health Innovation Manchester. And my role is to support and empower internal and external colleagues to include the public and the diverse communities of Greater Manchester in their projects and programmes. So Health Innovation Manchester involves the public in many different ways, but one of these is our public and community panel. The panel brings together 15 local people from different backgrounds that have a wide range of skills, knowledge and lived experience to bring to our work.
Hello, I'm Pat Walkington and I'm a real live member of the panel, just to show you that the panel really exists. And in addition to my current role with the panel, over the years I have taken part in many public involvement opportunities, such as working on funding bids and being a co-applicant on research bids, involvement in strategy, setting up a young person's advisory group, product design and linking project teams to community groups. Could we have the next slide, please, Ola? So Nikki and I have co-designed today's session, and what we're going to cover is what is public and patient involvement, the value of public and patient involvement in the context of creating a secure data environment, and the SDE public and patient involvement plan. Back to you, Nikki.
Thank you, Pat. So there are various approaches to including the public, but to keep it simple for the purposes of today, we'll describe public and patient involvement as the process of actively including local people in a range of involvement and engagement activities and using the insights we gather to inform our work. So why is public involvement important and what value will it bring in the context of an SDE? Well, PPI should be seen as an investment, as public contributors are our critical friends. They can provide ongoing advice and guidance and help us avoid reputational damage and other costly mistakes. But building and maintaining public confidence and trust is crucial to creating SDEs and is the prerequisite really to realising some of our grand plans and the ambitions that we have in this space. So we need to take the public with us on this journey by involving them from the start and co-designing our approach. But the public are not a homogenous group, and local people will have different levels of knowledge and understanding. To many, data sharing and the value it can bring, both for research and to improve population health, is a total mystery. So PPI will create opportunities for us to disseminate accurate information, raise awareness, and educate different patient groups around the benefits of an SDE, whilst at the same time enabling us to understand the different perspectives, issues and concerns and use that learning to inform the directions of our work and the decisions we make. For example, the public might bring alternative and unexpected perspectives, ones we haven't previously considered, that challenge our unconscious bias and the assumptions we make. So we need to keep an open mind and be willing to make changes. Next slide, please, Ola. So the Office for National Statistics has developed a 5 SAFEs framework as outlined in this slide. And this is recognised as best practice in terms of data protection and the creation of SDEs. The five SAFEs will provide us with a useful framework for PPI discussions with different patient groups, which we plan to deliver across Greater Manchester, including in community venues that are accessible and familiar and where the public feel comfortable. Our activity will engage with existing PPI groups like our panel and perhaps patient participation groups linked into primary care. But we also plan to reach out to the people and communities that experience barriers, that are marginalised in some way, or where there might be deep-rooted mistrust. The insights we gather will help inform the governance structures necessary to build that public confidence and trust, such as representation at a programme board level and other decision-making groups. But the insights we gather can also help inform our comms, identifying the key messages that are important from a public and patient perspective, and enabling us to understand how these can be communicated really effectively across different patient groups and communities within GM. I'm going to hand over to Pat now, who's kindly agreed to share some of her learning from another data sharing project she recently supported.
So in January, I joined an advisory research group in Greater Manchester, which aimed to explore the views of local people around the sharing of health data. I was involved in the project discussions early on and was able to advise on public-facing materials and setting up the focus groups. For this, I used my local contacts so the project team could engage with an existing group that was willing to host some of the sessions. Let's face it, health data sharing isn't the most exciting topic for the public. So with help from the local park cafe manager and with the agreement of the 2 researchers, we arranged an informal open air focus group of diverse people who use the community allotments and volunteer in the community cafe in the park. What we learned from this first focus group and from a post-meeting with the host was that patients felt comfortable engaging in this environment, and it really helped that they all knew each other. One person was concerned that funding for the focus group would come from frontline NHS monies. This came as a complete surprise to us, but the project team were able to reassure the group that this wasn't the case. And we have borne this in mind for future focus groups. We found that by focusing our recruitment on marginalised groups, we had inadvertently excluded some people who would have liked to attend. And this was fed back to me in a post-meeting with the cafe manager. We also received free feedback from the park cafe manager that many of the people who attend the cafe are isolated and have few people to talk with about their problems. He said that joining the focus group had made the participants feel valued. It offered a learning opportunity and gave them a collective voice to say what they thought about health data sharing to independent people. That was to the project team. And using the feedback, the advisory group subsequently made a number of changes to the public-facing materials and how they worked with the focus groups moving forward. So this is just one example of the work that the PPI panel do. Thank you.
Thank you, Pat. So we're at the end of our section now, Kiran.
Okay, thank you very much. Thank you very much. So hopefully everybody's had a really good flavour of what the SDE is and some of the arrangements that have been put in place. We've got a time now allotted 20 minutes or so to ask any of the panel members questions. I know the panel have been very, very kind in answering a lot of the questions on the chat box, but I will take this opportunity to kind of maybe clarify some of the questions which they've not been able to answer. And if anybody does want to ask a question specifically, please feel free to raise your hand and I will come to you. So Claire Williams, you asked a question on governance, which I think the team would like you to expand on a little bit more so that they can answer that question for you. So Claire, are you happy to unmute yourself and ask that question specifically?
Hi, yes, thank you. I sit on 2 ethics committees nationally, and my question was really regarding the ethics approval for this approach. How would that work, and would that be generic, or would each research project be required to get their own ethical approval?
Okay, so who's going to take that for me?
Yeah, that's what we want for Niels, Kiran, that's it.
Yeah, Niels,
if you're happy to do it.
Yeah, I'm happy to take that one. So how it will work is that we're going to have generic approval for studies that use the data that are routinely held in the ADSP. I think for studies that need to link data that are outside of the SDE, the ADSP, so for instance, that use data from an existing cohort and want to link that to electronic health records, we will need a separate application to the CAG. Unless that cohort study already has patient consent for linkage to electronic health records. So there's 2 options there. Cohort studies that prospective cohort studies that have asked patients for consent for linkage to electronic health records. There it will be relatively straightforward, but otherwise we will need a separate approval. Jenny, I hope that I've covered that correctly.
Jenny, did you want to add anything to that?
Not really. I'm not really ethics.
Okay, so the other question, Connie, would you like to expand on your question as well, if that's possible?
Corinne, I think.
Corinne, sorry, apologies. Corinne?
Hi, yes, I'm sitting with colleagues here, Gareth and others. So yes, I had a question, well, similar questions around governance. And I guess we were just discussing within the group, if you have an approval for a trusted research environment, as we do have at the Christie, and then you obtain an approval through CAG for the Manchester SDE, does that mean that you can proceed with analysis without a further approval?
Okay. Can anybody help with that?
I can try and take that one. Yeah, and then I'm sure Jenny will come in and tell me that I've got everything absolutely wrong, as is often the case. Yeah, thank you for your question, Corinne. I think just to offer, I suppose, first off, some assurance in terms of the approach that we've taken through our GM program. I think it's relevant for a couple of questions that have come up in the chat. So this is a GM SDE initiative, and we're developing our secure data environment, building on the analytic data science platform. But it's very much a joint effort with partners from all across Greater Manchester. So alongside some of the key members that you can see represented on the group today, we have a delivery group that meets every fortnight. It has 5 work streams, technical work streams, research work streams, IG work streams, etc., that deliver in terms of some of the detail. And then an overarching program board with very senior representation from across key partners from across GM. So Fiona, who's obviously the director of R&I over at the Christie, sits on our program board, and we very much value Fiona's input. We have similar input from colleagues from MFT and the NCA as well. So we've always designed the SDE approach to look at how do we collaborate at city region level rather than supersede or replace any of the great activity that's already going on within our trusts and within our various organisations. I think in terms of the specific point about CAG approval, certainly my assumption would be that if we had CAG approval for the Christie data sets in the environment that you've outlined, and we had CAG approval for the data that's in the SDP, for the ADSP, sorry, then absolutely we could crack on in terms of conducting analysis, and we'd consider that through the usual approval process.
Yeah, thank you very much for that. And we just also, if I may, Gareth has posted another question that is important. I mean, obviously, we're trying to develop something for the Greater Manchester area, but to some extent, you know, what is going on at national level, and should we not be looking, or not, when I say we, should NHS Digital not be looking to do this kind of general, or developing a general approval for the use of data within the NHS, as opposed to us doing it for just the Greater Manchester area?
Yeah, absolutely. I can take that one first if you like, Kiran, and then I'm sure Matt may want to come in just in terms of some of the national work as well around other platforms of governance, etc. So I think I mentioned briefly in the chat that the section 251 application and the CAG approval, etc., that we're developing for Greater Manchester, we're doing that process very much in parallel with conversations with the national team, Claire Bloomfield from NHSE and others, around how we may consider almost like a class action approval for secure data environments. And many of you will be aware that CAG generally approve use cases of different types, essentially. So once you have a use case that's approved under a certain type, then subsequent use cases are almost covered by that initial approval. So the idea would be that rather than having every single SDE across the country, of which there'll be several, submitting parallel section 251 applications, essentially approval from CAG for one SDE acts as approval for lots of SDEs if they're comparable between one another. I think there's probably an element of your question as well, Corinne, just in terms of how does the local architecture and the technology then relate to some of the national stuff. And just to give you an idea in terms of the picture, the intention from NHSE is that there'll essentially be two parallel arms. So there'll be a national secure data environment, which will sit on top of some of the national data sets, as Matt, I'm sure, can expand on. But then in parallel to that, there will be these sub-national SDEs and some model for federation between the sub-national SDEs. And I think there are a number of benefits of sub-national SDEs above and beyond the national approach. So if we think about the kind of process that we're putting in place in GM, it means you have much greater agility and quickness of access to the data. The data is often much more timely when it's in an SDE because it doesn't have to go through national processes, which can take time. You have much closer proximity to the change and to the data controllers, and can build and maintain those relationships. So a number of benefits, I think, over of sub-national SDEs over national SDEs, but that model of federation is a really exciting space and something that's being continually explored. Matt, do you want to add anything to that?
Thanks a lot.
Oh, you're on mute, Matt, sorry. Yeah, I think we try again, Matt. Nope.
I don't know if it's your microphone, Matt.
Shall I come back to you, and if I go and ask somebody else? I'm going to try and bring in a number of other people who've asked questions on the chat box. So I'm going to turn in no particular order to, I'll go to Peter Crowther first, and then Zohar Kapas and Sean Rowick. So if we go to Peter first, Peter Crowther. I know you've asked a number of questions, Peter. If you would kind of maybe pick one that's most important to you, and that you don't feel we've answered yet.
I'm a known troublemaker. I was also, I mean, some people will know me as the original architect on Salford lung study and the like. Key one here, assuming you're ever going to use this for clinical studies, clinical trials, then whoever is consuming this data has to have the ability to audit the SDE to an appropriate level for themselves, to ensure that that system is appropriate for their use. Potentially, if they are deploying their own analytical software on it, then that software needs to be validated. So if they are, for example, using R scripts for analysis, I would be concerned if they did not validate R and the systems underlying that down to the machine level. What facilities are there to do that? You know, if somebody comes in from a pharma company and says, hello, I'd like to do a site visit. I'm going to send 2 of my auditors in for 3 days. What do you do next?
Okay, so who's going to take that one? Bradley, you're going to start that one off, yeah?
I can start that one off, Kiran, and then Niels may want to come in more from a research perspective. So yeah, thank you, Peter. I think it's a very pertinent question and something which we are actively considering at the moment. I think it would be an illusion to say that we've solved it in terms of the SDE. We absolutely haven't, in terms of how we use the analytic data science platform to support clinical trials. But it's absolutely our ambition to do so in the future. So I think Niels alluded to, and I touched briefly in my session on this extensive requirements gathering piece that we're undertaking currently. And that requirements gathering piece is structured around a number of different use case areas, one of which is in relation to clinical trials. And as part of that, what we want to try and surface from end users, including academic end users, but also industry partners, etc., is the kind of feature functionality and capabilities that have to be available in the secure data environment to help to inform our investment roadmap and our product roadmap and future development. So absolutely, you couldn't use today the secure data environment to deliver traditional randomized controlled trials, but it's our ambition to look at how that may support that activity in the future. In the first instance, that might be through things like how we do cohort identification, feasibility, look at exploring recruitment and population numbers, etc. Over time, we may look at things like compliance with the good clinical practice guidance, etc. So we can start to use that in a more involved way to support some hybrid studies, for example. But definitely, we're not there today. It's something that we're really interested in exploring, and we need to through the requirements piece, and somewhere that we'll be investing in as we move forward.
What quality systems do you already have?
I'm going to hand over to Niels just to comment, not necessarily in terms of quality systems, but just generally in terms of if there's anything you want to add, Niels, around clinical trials.
Yeah, no, I think Peter, it would be useful to have a separate conversation. Following up on this meeting, because I think you're absolutely right that we need those things. I think what's important for us that we define what it is and what it isn't that we're going to support in the trial space, right? And I think certainly what happened in the Salford lung study, that's, was extremely ambitious, certainly for that time, but in many ways it would still be. I think we need to define, what it is, certainly in the short term, we are going to support, and then perhaps define a roadmap of, the different aspects of clinical trials that we aim to support via the SDE. And that might perhaps always be less than what was done in the Salford lung study. But nevertheless, I think there is certainly scope to support a number of tasks via the SDE in clinical trials.
Okay, we should probably organise a brew somewhere.
Yeah, we should.
Thank you, Peter, for your interest and input as well. Thank you very much. So I'm going to go to Zohir Kapisi, and I apologize if I...
No, that's fine. That's fine. Thanks, Kiran. This is of course very timely, and just to let you know that within the HRA we're working with others, including Claire Bloomfield, just to develop an overarching framework for regulatory approval across SDEs within the UK. So to drive that efficiency, but really my question is to understand whether there is a facility to ingest and stack multi-center data from sites beyond the UK, and maybe what's the understanding there.
So who's going to take that? Bradley?
I can, Kiran. You're probably sick of hearing from me, to be honest. Matt may want to come in on this if Matt's technology is working okay. But so I suppose one of the bits, I guess, that I would add from a program perspective, and then Matt can comment, I guess, from more of a technology and kind of GM architecture perspective, is one of our core principles from the very outset of all of this work, including the work that we did previously on the GM care record, and now we're transitioning to the SDE, is that we have to be able to demonstrate benefit back to the Greater Manchester population. We've got to be able to show either that any of the partners that we're working with, that the data that we're using comes through a GM organisation. So that could be one of our higher education institutes, universities, etc. It could be a health and care organisation, our local authorities, our provider trust, the ICB, etc. So there has to be that partnership arrangement, because this is a Greater Manchester SDE, and we have to show how we show benefits back to the citizens of Greater Manchester directly as well. That's a very explicit part of our application and approval process, is how do we demonstrate that benefit back to our local population.
Thank you. Matt, I believe have you solved your issues? Yeah?
Am I working? Am I working?
Yes, you are. Thank you, Matt.
Thanks. Sorry about that. Yeah, I think Bradley answered it. I think so the application, if you like, the trusted research bit that sits within the SDE. The application we're currently using is an eLab application, which is I like to think of it as a sort of porter cabin that gets spun up in a big warehouse, and you serve into the porter cabin the data you need, but the porter cabin comes fully fitted with the sort of technologies that you would need to actually conduct the research. Now that application has been tested across sort of international boundaries. So I know the University of Manchester use it on research projects because it's a web application with Harvard University and others. So I think the capability exists within that. What we're working through, as Bradley says, is a sort of protocol that ensures that the access to data is benefiting GM patients and the people whose data it is, but also that we can continue to maintain the safeguards that are currently applied in those research data sets in eLabs when the eLab sits within the secure data environment.
Okay, thanks.
Thanks, Matt. Sean, are you happy to raise your issue?
Yeah, can you hear me okay?
Yes, I can hear you perfectly.
So I think Neil's talked a little bit about privacy enhancing technologies. So I guess my question was a little bit about that. So it's how do we decide where to use privacy enhancing technologies? And I'm thinking maybe the use of synthetic data. And I guess the challenge that I put to you is that how, surely all patient data should be super secure. So how do you decide it over, one over another, which one should be more secure by using privacy enhancing technologies?
So who's going to, Niels, are you happy to say that?
Yeah, I'll pick that up. So thanks, Sean, for raising that, and it's a really important topic. I think what we always try to do and have done so far with the Greater Manchester Care Record is try to basically minimize exposure of data to researchers wherever possible, which is also, one of the GDPR principles. So we have a very small team of people, our research data engineers, who have access to everything, but researchers never get access to everything. They receive only the data that they need to conduct their study, and sometimes that's only a couple of thousand patients with a limited number of variables. So that's how we always work. Now, I think there are a number of scenarios where we might want to go even further than that. So, for instance, where we would ask people to write their script on synthetic data, and our people, so the research data engineers, then run the scripts on the actual data. So researchers would not be exposed to the data at all. I think we have to define, together with patients and the public, and with other stakeholders, with data controllers, what is acceptable when. So the approach that we currently have has been deemed acceptable by those stakeholders, but it doesn't cover everything. So, for instance, at the moment, we've not worked with any companies at all when we analyzed the Greater Manchester Care Record. As was discussed today, we want to change that. We do want to work with industry, but I think we have to define really, really carefully what is going to be the process and to what extent would those industry partners be exposed to the actual data at all. And maybe they wouldn't, but they would still get the results that they need.
Okay. Bradley?
Yeah, thanks, Kiran. I just wanted to add to a lot of what Neil said already in the and I think that, as Matt alluded to in his section, the SDE and the Analytics Data Science platform is intended to be a tool belt of different resources and different capabilities, and privacy enhancing techniques is one of those tools as part of that belt. And that could involve things like, as Neil's alluded to, using synthetic data so that we were maintaining an additional barrier between people accessing the actual data and then conducting the research, etc., and executing queries. But it could involve other things like how we might use suppression and stuff like k-anonymity and some of the open source tools like amnesia to support privacy enhancing techniques as well. So I think it's about how we ensure we have the right tools and capabilities in our belt, and to consider that almost on a use case by use case basis. It's always this grey area of risk and how we manage risk and make sure we've got utility in the data that we've got, but do that in a way which still provides that assurance and that security to patients and members of the public and citizens as well.
Thank you very much, Brad. And we've got probably time for one more question. So I'm going to ask Colin Pye, if you would like to ask your question.
Yes, if you can you all hear me okay?
Yes, I can hear you, Colin. Yes, that's fine.
Okay, excellent. First of all, thanks very much for an excellent series of presentations. My question, you mentioned about the SDE and to be used for both research and operational needs, and a decision was taken on that. I think it was Bradley, you mentioned that. My question is around the structure you have in terms of the groups that maybe analyse patient or person-centric flow across a system, which is particularly relevant, I think, at the ICS level, given that we're bringing the NHS together with care organisations, because we see bottlenecks in the system from front-end ambulances in the NHS to back-end discharge and issues within there. Is there a structure you have around that analyses the flow?
Matt, are you taking that one?
Yes, I can take that. The answer is yes. We have in Greater Manchester, we've had there's a flow journey, isn't there? There's the front door and the activity around ambulances and the front door, and then there's what we all know and have heard through news stories about the inability to discharge patients into adult social care or into the community more generally without the right care packages. So there are within the Greater Manchester system, there are groups that look at each of those individual pinch points. NHS England has asked integrated care boards across the country to establish sort of what they're calling system control centres by tomorrow. So we have what we're doing is putting those groups and those pinch point analysis together to give a system-wide view on flow. And I think a key part of your question is that that you mentioned that we're talking about a system here and not just the NHS. So one of the things that we're actively working out is, given the restrictions we've got, which is that we'll get health data into our SDE, but we won't be able to share it out. People will have to come to the SDE to access it. How do we then have conversations about linking to non-health data and you know, there's been recent rather tragic news stories about health and housing and the strong relationship between those wider determinants of health. So we've actually within our infrastructure conversations, we're talking about using perhaps a data mesh model where data doesn't need to leave the environment, but we can connect up environments such as housing provider environments or local government environments and still maintain the level of connection and insight that we need.
Thank you, Matt. So I'm going to bring in Bradley, and then just before I bring in Bradley, if any of the speakers want to have any final thoughts before we wrap the event up, can you just put your hand up as well, so I'll come to you. Bradley.
Yeah, thanks, Kiran. I've said enough already, so I'll keep it brief. But I suppose just wanted to build on what Matt said, that you know, part of what makes what we're doing around the SDE different, I suppose, is the scale at which we're looking to achieve this across Greater Manchester. I know we've had some discussions already today about all of the fantastic work that's happened before, like the Salford Lung study and work that we've done through the Christine MFT, etc. But absolutely, we in GM are leading the way in terms of how we start to analyse this data at kind of population, city, region, ICS level with 3 million patients, etc. So I think a lot of what Matt's touched on in terms of that translation between research and operational practice comes through the way that we are operating as an integrated care system, through devolution and the way that we operate as a Greater Manchester system. And I really wanted to emphasise that. But I'm going to be quiet, Kiran, because I've said tons already.
we're just over 11 o'clock now. So I mean, any final thoughts from any of the panel members? Jenny first, and if you just raise your hand, I can kind of bring you in. Jenny first.
Yeah, I just want to say the questions have been fantastic in the chat, and I didn't go through answering them because I was interested in listening to the other presentations as well. But we'll absolutely make sure that we respond to those questions. But to thank everybody for putting those in.
And I will echo that. I think it is always hard to kind of keep both things going. So we have collected all of those questions, and as I said at the front, what we will do is produce the FAQ response to all of those. As with all events like this, we can only kind of barely scratch at it, and the time goes really, really quickly. So again, apologies if I've not got around to asking one of your questions, but we will endeavour to do that offline. And we have your email addresses, so we will be able to forward those to you. And we will also probably ask for some feedback on the event. I know some of you have been already very kind on the chat, but we would like some feedback as to whether the event worked well for you and covered the right topics. I hope you recognise that this is an exciting thing that has been created by the team here, and which will help the people of Greater Manchester. And it was really good to have Nick and Pat on board to kind of explain how they help us to achieve some of that penetration into the public. And of course, the team with all the technical expertise, I thank you very much for taking your time out to present what you've been doing with the secure data environment. And I have also found it very interesting, even though I chair the secondary users group. I think sometimes having just time to think and listen without having to chair it is also good. So I thank every one of you for the presentations, and all of those who've joined this morning. Thank you very much for the interest that you've shown, and please feedback. And also there's links there that Ruth has posted for you to kind of have more involvement in this process going forward. So thank you very much, everybody.